Thank you very much for this opportunity. We have the colleague from Freiburg, so I just make a very quick introduction for this first series of a webinar, and I will leave the speech to Ilaria Mellone, that I really thank you, and to Rossella Rispoli that have organized this event. So I just say hello and thank you to the host. Thank you very much for this opportunity, and please I ask Rossella to introduce a little bit Ilaria, and then Ilaria can start. Thank you very much to everybody to be here.
Okay, thanks Francesco. Good evening everybody. I am very happy to introduce a good neurosurgeon and a very good friend, Dr. Ilaria Melloni, and the webinar that she organized on the Cefalea Spinale. Okay, Ilaria, you can start.
Grazie mille Francesco e Rossella per l'invito e per la possibilità di organizzare questo webinar. Dico due parole in italiano solo per i colleghi italiani per cortesia. E allora abbiamo deciso di organizzare questo webinar su un argomento particolare che è magari meno parte della quotidianità dei chirurghi spinali, ma è di fatto un problema estremamente diffuso, che è la sindrome da ipotensione liquorale. La sindrome di ipotensione liquorale, seppur sempre un problema cranico, è a tutti gli effetti un problema spinale, perché è sempre causato dalla fuoriuscita di liquor nel canale vertebrale, con diverse modalità. E quello che è sorprendente è che è un problema del tutto guaribile. I pazienti affetti da questo tipo di patologia sono pazienti che hanno una qualità di vita estremamente ridotta e che non riescono a lavorare, sono tendenzialmente pazienti giovani, e sono pazienti che quando vengono introdotti nel giusto percorso diagnostico e terapeutico riescono davvero a guarire e a stare meglio e a ritornare alla vita precedente. È un problema estremamente sottodiagnosticato, sono pazienti presenti nelle nostre vite che non riusciamo spesso a riconoscere. L'incidenza di questa patologia è stimata a 5 su 100.000 abitanti l'anno, che è quasi l'incidenza dell'ESA, che è molto più la normalità del neurochirurgo. Ma sono pazienti che non troviamo, e sono pazienti che soffrono, e pazienti che possiamo guarire con la chirurgia spinale. Ho scelto questo argomento perché credo che ci sia meno consapevolezza nella nostra comunità per quello che riguarda questo tipo di patologia, e abbiamo invitato dei colleghi dell'Università di Friburgo, del gruppo Jürgen Beck, che è il punto di riferimento in Europa per questo tipo di patologia. È quello che ha cambiato il paradigma del trattamento di questa patologia, che ci ha fatto capire come funziona e come i pazienti possono essere curati. E noi abbiamo un'esperienza relativamente limitata. Abbiamo cominciato da qualche tempo a occuparci in modo molto più organico e molto più sistematico di questi pazienti, seguendoli, costruendo protocolli, costruendo una collaborazione con i neurologi e neuroradiologi, in modo da riuscire a collocare questi pazienti e a seguirli nel tempo. E per questo è stato importantissimo per noi la collaborazione col gruppo di Friburgo, che sono stati sempre estremamente disponibili, collaborativi nei nostri confronti, ci hanno accompagnato in questi passi, per cui ci è sembrato più corretto e anche più utile per tutta la comunità far parlare direttamente loro, e quindi abbiamo invitato la dottoressa Wolf e il dottor Hall dell'Università di Friburgo, che sono rispettivamente una neurologa che si occupa di questo tipo di patologia e un neurochirurgo. So I'm very happy to introduce Dr. Katharina Wolf and Dr. Hall from the University of Freiburg, and I'm very honored to introduce you, and I'm very grateful to you, and I'm so happy that you can share all your experience and all your expertise with us, and to share all your knowledge and the results of all your studies that helped all the scientific community to be aware and to properly treat these patients. And Amir has been a friend for a long time, so I particularly thank him, and also thank Katharina Wolf, which is an excellent neurologist and an excellent speaker also. So please, I'll let you speak. Thank you again.
Well, thank you, Ilaria, and thank you for the team for inviting us and giving us a chance to talk about what we love to talk about most. And it was such a pleasure having you here in Freiburg. I'm sure you could give the talk yourself, but of course, we always are happy to present what we are doing. So maybe I will do the start as always. I will do the neurology part, and then Amir will skip in and actually present how to treat the patients. Now let me see how I can do this. Now you should see my talk, I guess. Can you give me a swift feedback? Do you see the full screen?
Perfect. Thank you, Katarina.
Perfect.
More?
Okay. So
No, not anymore.
not anymore?
No.
Okay. So I probably do you?
Now we see all the patients that you're treating.
Okay, perfect.
Okay,
So now we
okay.
get a link here.
Okay. Thank you, Katarina.
Let me switch screens.
Okay.
Sorry, I will switch.
Katharina, geh
Ja.
mal links, Anzeigeeinstellung, oben. Go back to PowerPoint. Up left, you have
Was?
Anzeigeeinstellung. Auf
Bei
PowerPoint,
PowerPoint?
geh mal. Ja. Da, oben left,
Okay.
genau, Anzeigeeinstellung.
Perfect.
Genau. Yes, you got it.
Okay, now we go. Thank you for that. Okay, so I will shortly introduce the topic, our team, and talk a little bit about basic diagnostics and treatment in spontaneous intracranial hypertension. So I will usually use the acronym SIH if I speak, and please interrupt me if there is anything unclear or needs to be clarification in this. Okay, now this is not okay. So I will shortly present. This is the outline of my talk, and this is where we are at. As Europeans, you are more familiar than usually our usual audience. So we are close to the Swiss border in the south of Germany. It's terribly hot, and probably you can relate. And this is how Freiburg looks like. Not nearly as pretty as most of your cities. A small medieval town. And this is our hospital, our new center, just photographed from top front, where we treat our patients. And this is one at the side of our neuro center with this graffiti of the black boxes, which we're trying to solve here. We see ourselves as a CSF center, so SIH, spontaneous intracranial hypotension, is just part of what we are looking into. We also treat patients with hypertension, patients with chronic postural puncture headache, and of course, normal pressure hydrocephalus and patients with hydrocephalus, everything that's related to that, like Chiari malformations and myelin herniation. So this is, in our point of view, it's a spectrum of diseases where SIH is one part of it that also is very important to resolve brain health in regards to CSF homeostasis. This is how our CSF center is built up with a broad basis on nurses. We have a SIH nurse, we have a collaboration with different disciplines. And I think this is very crucial, that you need to build a team in order to diagnose and treat those patients. And of course, it's not me, it's not Amir by ourselves, it's the entire team where everything is based on. And of course, it's important now to introduce Jürgen Beck, who founded the CSF Center in 2018 in Freiburg and founded the CSF Center before that in Bern. What are we actually looking into? So this is, if you look into PubMed, if you look into some data, what's out there on SIH, and you find roughly 4,000 results. It's got the same incidence as subarachnoid hemorrhage, and you know there's much out there. So we always need to keep in mind that what are we looking into? We are looking into experience, and we are looking what experts tell you, and just very, very few structured data here. So this is what Freiburg is looking into. We have been growing, we started slow, and then with the exponential growth, it exceeds our capacity, and that will happen everywhere where you start building CSF centers. We currently have 500 consultations per year, numbers still rising. The team in Freiburg, especially Jürgen Beck, is looking into more than 400 surgeries in SIH, actually. And we do a lot of blood patching and, of course, a lot of research aiming to improve what we are doing in any means. Again, what is the incidence? I think Elanya already mentioned this. We are looking in roughly 4 to 5 per 100,000 per year. So in Italy, you should see more than 2,000 patients with SIH per year. In Germany, we should see more than 3,000 patients, and still, like, our 500 consultations do not nearly cover what we should be seeing. So let me introduce SIH. SIH is a disease that is caused by a spinal leak. So it's either a dural tear, and we classify them in type 1 leaks, ventral leaks at the ventral spinal cord, or type 2 leaks at the lateral dura. Usually they're located in the thoracic spine. Then we have type 3 leaks, that's the CSF venous fistula, and CS venous fistula is a connection of a draining vein directly to the CSF space. So we have an efflux of CSF directly into the veins. Also, there are really rare causes like sacral dural tears. So that's exactly a dural rip at the sacrum, usually with some trauma prior to that. And we, or our team, just recently described with Nicholas Litzen a primary CSF lymphatic fistula, where the CSF drains into the lymph system. At least that's one case we found, and probably there are more out there. What happens? The CSF oozes out at the side of the spine, and what happens is, due to the Monro-Kelly hypothesis, the intracranial volumes increase. So you have an increase in the venous, in the veins. We have a brain sagging. Everything is sucked downwards. The entire brainstem is compressed, and we get a hyperemia of the meninges. I will go into that later, talking about images. So this is the normal brain. CSF leaks out. Everything sags down. And what happens? I think the most known symptom in SIH are orthostatic headaches. So a headache that worsens once you get up. Also, the symptom comprises many more deficits and symptoms. So we have a lot of cochlear and vertigo related symptoms, change in hearing, muffled hearing, double hearing, and so on. We have visual disturbances, we have cognitive impairment, and a lot of other accompanying symptoms that are really sometimes very distracting, especially in the outpatient clinic for neurologists to pick on that this is orthostatic headache. But what's really important, almost 90% of those patients present with orthostatic headache as one of their main features, and 70% present with subacute or acute beginning. So patients that the date of their beginning of headaches, that you must think SIH is very a unique feature here. What makes it difficult to get the high? Sorry? Can you repeat? Okay, so I will just go on. We have a large inter-individual variability, so not every patient might present. And also over time, it's very common that symptoms change, they fluctuate. We look into fluid dynamics, so it's not a fixed brain damage. Yeah, those are fluids that react to within the individual. It might not be the same every day, every hour of the day, or not every day of the week. And also over time, some patients might more present with cognitive impairment and others more with hearing disorders. Yet, if you go back and ask about the beginning, you usually pick up on the main symptom, orthostatic symptom, and the acute begin of SIH. So this is a really nice picture about the many symptoms that can happen. And if you see that there are many pitfalls you can step into, and I've just summarized them. I don't go over them, but there are many pitfalls you can mistake SIH too. And again, if you see all these symptoms occurring, then it's more than obvious that SIH is not just a headache. It's a tremendous impairment in quality of life. And what's really nice, and I just picked out this one example of Florian Folz's study, that if we treat them correctly, their headache intensity decreases tremendously, more than any other headache studies show. and their quality of life. So all these symptoms, everything that impairs them, increases and is almost normal after that. Let's step now into basic diagnostics and treatment. So the first and most important step is that you do MRI, and it's important that you do proper MRI. It's MRI of the head, so a T1 MPH with gadolinium, and it needs to be a high resolution, heavily T2 weighted fat set of the spine. You want to look for the signs of the head we already talked about early on, so engorgement of the veins, perimeningeal enhancement, brain sagging, and you want to look for fluid oozing out of the dural tear. And you can only discern that if you do proper imaging. If you just do some T2 on the spine, then it's hard guesswork. You will only find a huge huge epidural fluid. If you see an image like that, this is SIH. That is not meningitis. That's not Chiari malformation. You can tell by the slope of the chiasma that this is not Chiari malformation. There's nothing to think about. This is SIH. It needs to be no-brainer. Also, there's some help in scoring. The group with Professor Beck, when he started the CSF Center in Bern, they developed something that's now called the Bern score. And you measure distances, the suprasellar cistern, the mammapontine distance, and the prepontine distance. And then you look for perimeningeal enhancement and engorgement of the veins and subdural fluid, even subdural hematoma, and you add those points you get, and at a scoring point of 3 to 4, you have an intermediate probability of a spinal CSF leak, and everything higher than 5. This is SIH for sure. That's for sure that you will find a SIH spinal CSF leak. Also, let's look into what's really SIH. That's the image I showed you beforehand. That's a true no-brainer. But this is just to show you, you really need to get used into looking into this. This was scored normal in the other place, but you do have a full-blown Bern score of 9 points. All the features are shown with some errors, not in the right place. So this should show up to the meningeal enhancement and this to the vein, but I think you can follow me. This is a Bern score 6, so also a very, very high likelihood of a spinal CSF leak. Yet again, you see more space in the CSF around the brainstem, but yet this is no-brainer if you're used into looking into SIH imaging. Also, we can have Bern score 0. This doesn't exclude SIH. This is very important. So if the story is correct, then you still follow this patient. You might look into optic nerve sheet. If this is really empty, if you use a fat set MRI, then empty nerve sheets are very, very significant into predicting spinal CSF leaks. And you look to the spine. In the spine, we look for this epidural fluid. And there's this acronym SLAC that we usually use. So we are now calling head positive, SLAC positive, and so on, going on when we talk to other SIH patients. So SLAC might something I might use. I will try not to, so you can follow clearly. SLAC is the outflow of CSF into the epidural space. So this is an image of the spine where you can see SLAC throughout the spine, large SLAC. But if you want to look for smaller SLAC, it's very important that you have the right imaging to catch up on this. What do you know now? You know that you do have a leak, and you know that it must be a dural tear, but you have no idea where this leak is at. No MRI imaging will now show you where to do surgery. And this is very important. So everything you know by now is that this patient has got SIH. You don't know the level of the leak. One tiny thing I would really like to point out, because it's often mistaken, it's the so-called false localizing sign. Sometimes in the MRI or even in the CT, you find the contrast CT. With contrast, obviously, that's the original publication by Wouter Schilling, one of the godfathers of SIH. You can see some seeming egress in the upper thoracic spine, C1, C2. This is a false localizing sign. It's just a fluid collection. The leak is never up here, so be aware of that. So this is no point going after this. The leak is elsewhere. Let's now look into what we are going to do now. So you know this patient has SIH. You go into basic treatment. The thing that you read first is rest, drink, wait, stay at bed, wait till your symptoms go. This is reported to be effective in 25% of the patients within 2 months. So laying in bed for 2 months is something we really don't want our patients to do. And what is effective? Seriously, effective means you're getting better. All the patients are getting better. So this is something you do anyway while you go into proper treatment. There's also some medication you can use, like caffeine or theophylline combination, and there is some RCTs out there. Actually, they're not really clear, even though between favoring placebo or the medication, but it's something you can use to bridge the patient. And then the real symptomatic treatment is an epidural blood patch. I purposely call it symptomatic. It's not going to seal the leak. It's going to help the patient. So many patients will feel some relief. It's the treatment you do to get a patient out of bed. And long-term improvement is even reported in up to 50% after repeated blood patching. So this is something that helps the patient. But if we look into data, it does not seal the leak. 70% SLEC positive patients, and of course there's a huge mix-up in this cohort. But if we look into SLEC positive patients with dual tear, 70% have been still positive, still having a leak after this treatment. And many other papers, you cannot actually read them because they did never do the follow-up. So one major takeout is whatever you do, you need to follow up, you need to make sure that this leak is closed. Why do we need to do this? There is sequelae in SIH. So what can happen in the acute phase and even in the prolonged phase is chronic subdural hematoma, and up to 40% as far as we know by the data. Sinus venous thrombosis is something that usually occurs in the acute phase, but it's serious. If you catch a sinus venous thrombosis and have a dural tear, then it's walking the line and it needs to be managed. Also, superficial cirrhosis is expected to occur in up to 15% over 10 years. So there is deterioration going on over the long run. So even as a patient is asymptomatic, this leak needs to be closed. Also, there are rare complications like brain sagging dementia that has underlying spinal CSF leak in 40%, spinal cord herniation, and bibrachial amyotrophy. So this might be even mistaken at ALS. And they usually don't present with headache as their forefront symptoms. So this is something where you really need, as I think SIH is a differential, but that's what you need to keep in mind if you treat a patient. You need to seal this leak. So now going into finding the leak, sealing the leak, and treating the complications. We'll cover AMI then after this. When would you see for a leak? So if the patient is showing signs after blood patching in the follow-ups, directly go into targeted treatment if there are already neurological deteriorations, or even just really in imaging. Also, again, always follow up. In the terms of finding the leak, it's now important again to split up our leak types. So we have the ventral leak and the lateral leak, the dual tears. So with those, we see epidural egress. So those are the ones showing in the MRI. So they are SLEC positive. And we have SLEC negative, so where we have the drainage directly in the venous system or the lymphatic system. This is our workup that we do in Freiburg, and this is far too large now for you to read, so I guide you through. First, patients come to us, we have a CSF board, usually they did already receive the lumbar blood patch, and then we are going to perform an MRI. If the MRI is SLEC positive, the next most crucial step is dynamic myelogram in brown precision tilted down. So the tilt table, or the patient needs to be head down. And there is a huge thing I'm not the person to talk about in general. Those is something you really need to have a skilled neuroradiologist performing those investigations. It's not a normal myelogram. It's the timing that's crucial, and the neuroradiologist really needs to be there live to adjust to what they're finding. So there's one option of finding a leak via digital subtraction myelogram, and I hope this video is running. Okay, so the patient is prone, and here you see the breach. So it's actually a live video Now, here we go again, breach. So now you have localized the leak. If you do a later follow-up CT after application of the dye into the spinal canal, you're just late. You have the same information as in the MRI. There's no win in that other than radiation to the patient. So this is crucial that no matter what you do, you need to find the exact spot. I put in here the sacral leaks. That's also a little bit tricky. Of course, then you need to get a dye to the sacrum, and that's again prone position, but with a tilt up, head tilt up. Let's look into lateral leaks. So they are slack positive. Then you need to find the leak on the lateral side. So the patient need to be placed at the lateral side where the leak is where you have the suspicion of the leak, and if you don't find it, you repeat on both sides. And this was one of the first description of the one very nice method of cone beam CT as an additional tool. And lateral leaks, here you can nicely see the arachnoid outpouch of the lateral leak, and where almost guess where the dural tear is. And this is a DSM of a lateral leak, where you can just see that there is something arriving at this nerve root. And now you see in the second picture, you see the actual dural egress. So this is something important you need to see. This might be just a diverticulum or a nerve root cyst. This is the actual egress of the CSF. So this is important to make sure that you catch this. Now to the one of the newest developments, or not things that have been discovered, and probably I think will make up more than 50% of all the leaks in the future, are CSF venous fistulas. And this is again a high resolution image. And what you see here, and this is something you need to aim for, you need to find a draining vein. There's no point in just looking into the meningeal diverticle. You need to see where the drainage way is. And sometimes it might be the lower level that drains up here towards usually the paravertebral venous plexus. I'll show you another image here. This is axial, where you can just see this is a typical CSF venous fistula with a vein egressing outside of, at the paravertebral plexus. Sometimes it can go inside into the dorsal paravertebral plexus, and then it's very difficult. Usually, Nicholas Litzer is now performing dynamic CT myelograms on those, and he's very successful in that. And there are also some tricks and tips that you need to learn about how to actually localize these venous fistulas. And by now, I think the field's got really good in this. Again, you need to have repeated myelograms, and you need to be there in order to adapt whether it's a high flow, low flow egress. Now, my time is up here, and my summary is mainly team up. You need to have a team in this. Maybe always the neurologists say that they are first, the most important, but in this, I think they really should not do harm and let the others work and help with the headache treatment after and before that, and guiding patients into diagnostics and treatment, and not hesitate to actually do a blood patch. And for this, I would just maybe point out that we are trying to build networks. We do this teaching visitorships where Ilani visited us last time. Next one is November, is already fully booked, but always happy to have visitors here. And we're trying to build a network registry to raise awareness, improve diagnostics and treatment. And you're always happy to reach out to us. So with that, I would like to thank and hand over to Amir, or unless you would like to discuss a couple of things right now, but well, happy to do whatever you decide is best.
Thank you, Katarina. I think we'll discuss everything at the end. So perfect. Maybe the picture is clearer. Okay, if it's okay with you. You, Amir. Thank you, Katarina.
Excellent. Do you see my screen?
Yes.
Big. Excellent. Yeah, Ilaria, thank you. Grazie per l'invito. Grazie, Francesco. It's always a pleasure. I've met Francesco Costa a few days ago in Amsterdam. We had one of our meetings basically about SIH over there, and we were really happy to connect. I'm not going to spend that much time. I'm Dr. Rahal. I'm one of the neurosurgeon consultants in Freiburg. Basically, I'm an oncologist, brain surgeon, initially to a lot of awake surgeries and glioma surgeries, but at the same time, I really had fun discovering this disease with Jürgen Beck and the whole team. Thank you, Katarina, for the introduction. I will skip this. You already talked about it. The slope of publications and the slope of incidence is also increasing. We have basically 3 different types of leaks. I'm going to try to address each type of leak surgically and to explain to you basically from A to Z how we do manage them. So we have this ventral leak. This is basically done and caused by a microsphere that will just cut the dura as a knife on the ventral side of the dura.
Amir, sorry, can you do the complete screen action on your computer?
Yeah, it's not working.
No.
Wait a bit. What do you see now?
Yeah, still what? No, still not the normal presentation where you work. So not.
Okay.
It's kind of full screen. It is in presenter mode.
Okay, perfect. Thank you.
Yeah.
Sorry.
Okay.
Sorry. So I will come back. So I talked about type 1 leaks, type 2 leaks. Katarina told you it's basically an outpouching of the arachnoidea at the level of the root. Basically, it's a slit in the dura, either at the shoulder level or at the axilla level. And then you will have a kind of outpouching of the arachnoidea here, and you have CSF flowing out next to it. It looks like this on a surgical picture, and we're going to address it. And finally, you have this new type of leak, or this CSF venous fistulas, which are direct connection between the thecal sac and the veins all around, either with the plexus or either with intravertebral veins. So it looks a bit messy when you have a look on microscope pictures, but you're gonna see them clearly. So as you understood, we addressed these pathologies a bit differently. One has to be addressed on the ventral side, the other one has to be addressed at the lateral side of the root, or at least at the axilla or pedicle side, and the final one might be even more distal. And this is how we manage them. Katarina talked about the fact that we have a few 100 surgeries. Again, I'm just insisting on the fact that it's a team. We have a big team working on it, and nothing would be feasible without them all. Let's start with the microsphere surgery or the ventral leaks. Those ventral leaks, we do address them from the back. Basically, we do a dorsolateral approach with a small keyhole fenestration on the back, and we address those ventral leaks from the side to the spinal cord. I will go step by step into the surgical management. This was a paper published by Beck 2019 about management. So as we told you, we are neurosurgeon. We do address all the things as neurosurgeon. So we come basically from behind. We cut the dentate. We rotate a bit the spinal cord, or at least we give a bit of space and freedom to the spinal cord in order to address the ventral side of the dura. And this is, I'm going to skip this video. This was initially done open. We stopped this since a few years. Now we do it mini-invasive with just a tubular retractor, 2 centimeter skin incision. We will address the level with the keyhole fenestration. I just put it a few measures here. It was also done by our team. We are able now to do like bone opening less than 10 to 15 millimeters. It's less than a 10-cent coin for European-speaking countries. There is other way to address those leaks. You're pretty familiar with it. You're all spine surgeons. There is all those complex transpedicular or costotransverse approaches, or even anterior approaches. We don't use them. We can address all the leaks from the back, and we avoid this kind of complex surgeries to address a ventral leak. This was also published by Jürgen Beck in 2022, the whole team. And I will show you, with this video, how it works. This is not the typical patient. She's BME of 40 or I don't know how much. We come up with the tubular retractor. Usually those patients are pretty skinny and pretty fit. In this case, she was, a bit overweight. Let's keep it simple. We come with a pretty long tube here in this case, and then you address the level with the keyhole fenestration. And as you can see here, in the tubular view, the ventral leak is on the side. Again, keyhole fenestration, we try to be a bit more lateral. We will aim the lateral side of the dura, the dorsolateral side of the dura. We will do a durotomy, and then we will come and cut the dentate in order just to give a bit of freedom to the spinal cord. You will not touch the spinal cord, but just give it a bit of freedom. Looks like this. So you have the dorsolateral durotomy here. Here is lateral, cranial, caudal, medial. You do the incision, then you cut the dentate. You don't touch or absolutely not manipulate the dura. You see that we're pulling on the dura on this side just to have the ventral leak immediately coming in front. And you see, this is the tricky move. It's basically not pushing the myelin or the spinal cord. It's just pulling the dura to our side in order to have the ventral leak in front of us. Then we used to historically suture those ventral leak. Nowadays, we stop this. We come from extradurally. We do put a patch of Tacosil or something similar from outside. We put a patch from inside. We let them stick together, and then we close the dura. Again, another video just to show you how it's done. It's a more recent video, durotomy. Then we come laterally, we pull on the dura, and you see this amazing hole with the microspur. We just flatten the microspur, and then we take it out with a small microdissector. So it's all microsurgery. So you get used to. Then we come with Tacosil from outside, epidural. You see it here intradurally. I will pull on the Tacosil a bit in order to have it properly inside, and then again intradural sealing with another Tacosil, and you close the dura as usual. This is the typical ventral leak. This is the incision at the dural level, 8 millimeters, and this is really the main step. Cut the dentate to be able to mobilize the dura and just to give a bit of freedom on the spinal. It's a spinal cord surgery. We like to call it like this. It's really a fine surgery. It can be really harmful. So don't step into it if you're not used to do spinal cord surgery. As we told you, we come from American Surgical School. Professor Beck is a vascular oncologist surgeon. He used to deal with cavernomas and stuff like this. And yeah, I'll skip this because it's maybe too complicated for this time. And this is the video. Just to let you know, you might encounter when operating those patients a lot of what we call neomembranes. You'll have the feeling that you're on the dura, but basically it's what we call pseudodura. It's not the official and the real dura, and you might see those membranes all around. And this is a long story, and we do put a lot of importance on those on these membranes because it's a key step to handle them. I will come and then treat those lateral leak. As you can see on the picture on the right side, this is basically how a lateral leak looks like. This is 2016, also from the boss. Slit at the axilla, and you will have outpouching of an arachnoid bleb, and then just underneath CSF oozing out. This has been again confirmed in 2024 from our group, and again 2025 from our group with this nice drawing here, as you can see. So the slit is here, outpouching of the arachnoidea, and CSF just oozing next to it. This was also, again, studied. It's really a hot topic, as I told you, from a group of the US, Sheaving, which is also a major surgeon in the field. And he described different type of leaks at the level of the pedicle, at the level of the nerve root sleeve, or at the level of the axilla. Doesn't matter. At the end of the day, it's all about a lateral slit all around the pedicle, either underneath or above. And you have to address it surgically differently with the keyhole fenestration. This is how it looks like in the early phase. This is a patient operated after a few weeks of symptoms. You see still this translucent, transparent arachnoidea just underneath the slit all around. Here is the root, and here are the veins, and this is the fecal sac. If you operate on those patients a few weeks after, or a few months after, you see how fibrous will this arachnoidal outpouching be, and how it can just change. This is more video to show you how we do it. So this time we're going to come also with a mini-invasive approach. As usual, we identify the leak. Sorry, the video stopped. Small fenestration. We identify the fecal sac. You see all those red membranes on top of it. And we dissect those membranes. We're going to expose the root a bit more laterally. In this case, you have to do a partial isthmotomy, a partial festectomy. The pedicle is here all around. This is the root, the fecal sac. We dissect all those membranes. We're going to plug this cyst again into the root. And now we see it well exposed. Here is the root. In this case, we couldn't save the root. This was a non-eloquent root, so we plucked the defect. You see that the defect is pretty big. We can suture it, Tachyseal, and clipping up the root. Another case of a type 2 leak, this time also small fenestration with the 3 tubers. Then we go laterally, we expose the cyst and we expose the root. You see how big this one is. This is the fecal sac, cranial medial. Again, we dissect those membranes. You see, we have a layer of membranes on top of the dura, and here you can start to see the dura, the fecal sac. Those are all membranes. We reduce the cyst. You see it here. It was an axillary defect plugged with a bit of Tachyseal and sutured it because it was feasible at this level. And then epidural sealing with Tachyseal, a bit of glue, and the job is done. So as I told you, it's really the pathology is not, it's not how we used to think. It's not like nerve root cyst or whatever. It's really a slit in the dura at the level of the axilla or the pedicle level. For eloquent root, you have to adopt different strategies. Either you can suture them. In this case, it was really a complex multiloculated diverticula. You can suture it. So what we do in this case is really to reduce the cyst, and then we're going to wrap the root with different layers of material. In this case, it was Duragen and Duramatrix. And then we will just put all the material together and clip the material in order to put some pressure on the root without clipping the root, just clipping the material in order to keep some pressure on top of it. So I'll come and proceed with the CSF venous fistulas. As I told you, those are pretty specific pathology and pretty specific cases. Those cases are a direct connection between the fecal sac and the epidural plexus and the epidural veins, and you have to address them differently. So the approach will be similar to a type 2 approach, but the question is, how are we sure that this pathology exists, and how can we really identify them? So I skipped this, you already saw amazing pictures from Katarina. We address them like this. The approach is the same as a type 2. I invite you to scan the QR code if you want to see. This was a paper that we published last year with a few videos and explanations. We address them the same way. Laterally, we don't coagulate the plexus. We don't coagulate the veins. You see those membranes on top of the dura. We dissect them. We'll send some pathology. And then here, we have the feeling that we identify the fistula points, but we're not sure. So we introduce a lumbar drain and we will inject fluorescein, sodium fluorescein, intrathecally. This is not FDA approved. This is not CA approved. So be sure that you're allowed to do it in your country. You'll see the root filling up. And a few seconds later, 2 minutes later, you see this vein here. It fills up. And when we push on the vein, it will again fill up with intrathecal fluorescein. It really signs the fistula point. So basically, we do a second check. As you can see, when you push and you pull on the vein, it fills up with contrast. Again, here it was a non-eloquent root. We wrap it, we clip it if needed. It's exactly the same. Sorry, do we have to look at this video? Yeah, sorry, you have the sound maybe. I'll just cut it. Again, fecal sac, root, and here we had the feeling that there was a single fistula point at this level with an epidural vein. We do the same procedure, intrathecal sodium fluorescein injection with really low doses. The protocol is also on the paper if you want to scan it and have it. Around 2 or 3 minutes later, the fecal sac fills up, and pretty slowly you see that the root is filling and the vein too. Exactly at the level where we had it, we will turn off the light and you see coagulate the vein. Here is the fistula point. We just closed it, in this case, without clipping. So again, sometimes you have a unique and one fistula point. Sometimes you have multiple fistula points, and the strategy has to be adapted depending on this. What I tried to show you is that basically we started with like open surgery, and we came pretty quickly to this really invasive approach with one approach fits all. And depending on the kind of pathology that you address, you can just use to put your tube in a different way in order to address them all with one kind of approach. There is alternative treatments to those CSF venous fistulas. It's really a hot topic since 5 years. There is a lot of research. This is the group of Bijinki and Gregory Cutforce. They treated 60 patients with embolization. They had partial improvement in 37, pretty good numbers, 60%, I would say 55% of improvement, but still not optimal. There is also a group of radiologists, and one of them is Niklas Lutzen and Andrew Kellern. They did this also with lateral leaks and CSF venous fistulas. They also had clinical improvement in 55 to 60% of those patients. It's also good numbers, but I do think that we can still improve, and there is a lot to do. If you compare to our cohort surgically treated, this was almost 60 or 70 patients treated for lateral leaks and CSF venous fistulas. In the case of a surgical treatment, we have 98% of improvement, and 85% of them are really much or really improved. So as Katarina told you, I'm going to skip this also pretty quickly. We have clear findings on imaging, and you have to identify those findings. Then you have to identify the causes of these imaging, and you have to address those leaks. Address them in different ways, address them with a stepwise procedure, or at least with a symptomatic relief. There was consensus guidelines done in 2023. It's a really quick evolving field, so those guidelines are almost not updated anymore and not up to date anymore. I would skip those videos. Reminder about the CSF visitorship. You're all more than welcome. And I will finish just with a few words about the outcome of patients. We talked about this. We measured the outcome of patients. You can also scan the QR code. It was a work done with Florian Folz and Katarina. Really a lot of patients included. We followed them with PROMS, patient-related outcome measures, and basically with an iPad. And we were able to show that after 3 months, patient improved dramatically. 16 points on the HIT score, and this score was developed for migraines and chronic daily headaches. And if you compare it to migraine, with 2 points, you're already happy when you are a neurologist. Sorry, Katarina, I have to hit on you a bit, guys. But with 2 points, neurologists are really happy with medication. In the case of a surgical managed SIH, you can improve them with a delta of 16, which is 8 times better. So we can conclude that surgeons are almost 10 times more efficient than neurologists. But this was just a small joke. If we just continue about what we have to do and how powerful we can be for those patients, it's now pre-established. The duration of symptoms is one of the most powerful outcome factor and predictor. Done for surgery, also done for radiological management. If you treat your patient under 3 to 6 months, they will have a better outcome. And the time to treatment is really the modifiable factor. And objectively, those patients are young, can't work, and have really low quality of life. It was really well done, shown by Katarina. But as you can see, once treated, 90% of them might go back to work, and 80% of them might be fully employed after 3 months of evaluation. Long-term sequelae, I skipped this. Katarina talked about quality of life. Quick 2 words about subdural hematomas. This is a group of young patients. When you do see subdural hematoma by patient under 60 years old, don't forget to try to search for the leak. Go for quest for the leak, seek for the leak. Don't stop until you find it. In patients with bilateral subdural hematomas, you might find up to 30% of leaks. This is a cohort going on. I'm sorry, I can't show you all the results. It has been submitted, and I will ask you not to record this and not to publish it, please, Ilaria. This is something under review nowadays, also work done by our group. We have now 270 patients, and we do have almost 80 of them, 30% having a subdural hematoma. And we're trying to get a guideline in order to manage them. I can't provide more, but please keep it open, brain and spine probably, and hopefully soon, in 2 or 3 weeks, I hope. And finally, I will just finish on this. Don't forget that you have long-term complications, and this is a complication that is pretty rare, superficial pseudosis. This complication has been seen in SIH patient and CSF leaks more and more of the last 3 years. And when you do treat patients with SIH and concomitant superficial pseudosis, you might improve patients. You might improve them for the superficial pseudosis disease. And this is also something that has been till now not addressed from our colleagues, neurologists. I'll skip this for a matter of time. You all know that there is a lot to do in SIH field. So don't forget to establish the diagnosis. It's not a benign disease. We do think that it's just the hole in the dura. Treat those patients, try to identify the leaks, and it's best managed in specialized centers. I would have loved to present you a lot more data, but we had a whole weekend in Amsterdam with almost, I think, 100 talks about the topic, and we didn't cover all the subjects. So we'd be really happy to meet you again, guys, hopefully in Italy once for a bigger symposium.
So thank you, Caterina. Thank you, Amir, for your splendid explanation and talks to us. We would like to pose some answers, of course, to ask for the issues that we discussed more about, to translate your experience and literature in our reality and the challenges we've been facing in this time addressing this pathology. If you agree, just some quick questions. If everybody from our colleagues want to ask questions, feel free to do that. I'll try to. Okay. Can you see the screen?
No, not yet.
Not yet.
Ilaria, scusa, se qualcuno ha delle domande può anche scriverle in chat, poi le riportiamo noi agli ospiti.
Okay. I'll try again.
Yeah.
Now? Is it working?
It's all black. Now it's working.
Okay, so this is the first question we would like to ask you, and Alberto Palestino and me will ask some quick questions about our challenges. We are basically the spine team in our ward, in our department, and the first thing is about imaging. So myelography is something that is technically difficult to do for neuroradiologists, and now neuroradiologists are not so experienced in myelography as some years ago. So it's not, in our experience, so easy to find the leak in the first myelography. So is it worth to repeat myelography when we don't find the leaks? And how many times, and which is the timing, do you think? And do you think there are some tips that could help us to find the leak?
I will maybe start, Katarina, and then you take over.
Definitely.
Yeah. Repeat the myelogram, absolutely. If you have a high suspicion of a CSF leak, you have a high SIH score, you're SLEC positive, do the first myelogram. I would still pay attention. These are young patients. So if you're not that experienced, I would repeat it maximum, I would say, one time before referring the patient to a highly specialized center. We do know from recent studies that myelograms are highly irradiating procedures, and you might cause long-term disease and long-term cancers. But still repeat it at least, I would say, one time before referring us. Then regarding tips, for every type of leaks, you have tips, for sure. We have the swimmer position for the type 1 leaks. You have the lateral position, the cubitus lateral for type 2 and type 3 leaks. And the best way to see how it's feasible and done is basically to have a look with a highly skilled radiologist. So recommend you to visit a center where it's performed on a daily basis before starting it. It's not that easy. It's really not that easy. This is the key of the pathology, basically.
Thank you. Alberto?
Absolutely. I might just add that there are by now very nice papers out just explicitly stating what are the leak types, what are like usually where to find them. So usually suspect which type, whether the upper thoracic spine ventral leaks, lower in venous fistulas for one, and also there are some actual leak guidance paper how to perform myelogram. Like the actual setup, but again, as Ami said, the radiation dose is not really low. If you just repeat and repeat, new radiologists actually go train and then exchange, build a network, so you can just exchange while you're going and ask for help on the developing the skills.
Thank you very much. Alberto?
Thank you, Lara. Thanks to our colleagues from Freiburg. And I want to put the second point of discussion we found is concerning asymptomatic patients. And I think we think it will be a challenge to know what to do if a patient has a positive MRI or a radiological sign or a diagnosis of SIH, but without symptoms, or at least without easily recognizable symptoms. Do you have to propose treatment or further clinical investigations?
Search for the leak. No discussions. You saw these long-term complications. They might get subdural years after. They might get superficial siderosis. They might get bibrachial amyotrophia. Just search for the leak. If you have a positive MRI, even if there is no symptoms at the moment, myelogram.
Even if complete. Oh, okay.
Even if he's completely asymptomatic, absolutely no symptoms, zero symptoms, positive MRI, just go for the myelogram.
Okay, I'll tell you the objection we had when we say that here, but you don't know how frequent this complication can be still. You don't know what is the rate of dementia in this patient, of the rate of siderosis.
I understand this is logistics. It's complicated everywhere, but I think it's all about communication. You have really to build a team with your radiologist and really to provide them also with insights. So don't hesitate, organize meetings, organize talks with specialists, come and visit with the radiologist, and then you will get them into it. You will get them into it.
Okay, I'll go into this question very quickly. I just want to show. No, I can't. Okay, it's not a problem. Okay, I wanted to talk about the guidelines. So there are 2023 guidelines which were published about SIH, and they say that we should perform 2 EBPs, untargeted EBPs, before searching for the leak. And at the beginning, we did it like that, but now we're changing our attitude, and we're not doing this anymore. I can't. Why it didn't work? Okay. Now we change our attitude, and in young patients, very symptomatic patients, we don't do blood patches anymore. We propose surgery, and we search for the leak before proposing an EBPs. What do you think about that? And I know so what Katerina showed us, but what do you think are the very symptomatic patients? For instance, we consider very symptomatic patients with neurological conditions, even patients with diplopia, orthostatic diplopia, or in very young patients.
Absolutely. I think it's just what like the high level centers by now do. If there is already, like as I put it, if there is already deterioration or neurological deficit, we would definitely go for targeted treatment. Since we know that the blood patching is doesn't do the trick, and there's more data coming up underscoring this. In the regard of the consensus guidelines, you always have to keep in mind how consensus guidelines are written at this level of evidence. And I think it's mainly based on what we have known so far on hypotensive headaches, but the data doesn't really support this. Nevertheless, I think we should keep in mind that blood patching is something feasible to do, and there's a huge data set from Ian Callum and his group, where they just showed they did not do any damage even after 10 blood patches, and so on. So what we should get out there, the blood patch is the first thing to get a patient out of bed. So do it, absolutely, especially if you're not capable of finding a leak. It's hard to find a leak. We just talked about this. So blood patch is the first thing to do. But currently we're discovering that likely after like 6 or 8 weeks into especially SLEC positive patients, there's hardly any chance of natural healing.
Okay, so in Italy we have this lawsuit problem of patients against us for almost everything. So this could be also a challenge for us to not to follow the guidelines, the published guidelines. Anyway, Alberto, sorry.
I totally agree with Katarina.
I think in the field there's no discussion about this, that the guidelines are absolutely outdated, and they should have been written in another focus, and even the like in the UK it switches, but it's always an effort to put guidelines out. It takes years, and the results of the years prior to that, and so on. So I think we are still in a developing field, but you need to be sure of what you're doing, also that you don't harm. And I think with the expertise growing, we can likely get more guidelines out, and they're already in prep.
Guys, I'm really sorry, Ilaria, Francesco, all the team, all of you guys. I really have to leave. I had a Zoom starting 10 minutes ago. I'm already late. Katarina will just continue the discussion. It was really, really a pleasure. Again, one more time, sorry. You can just have from my email from Ilaria if you have any questions, anything that you want to address, or the mail of Katarina. Thank you all.
Bye.
Thank you, Amir. We just have the last question, and then we'll let you go. And we thank you so much.
So sorry for being late, but the last question is about subdural hematomas. So that I don't know if you can see the screen, but
yes.
How to manage it? Because many people have how to manage it and the timing. If there is the choice of conservative treatment, middle meningeal artery embolization, or direct surgical evacuation, and with which timing.
Okay. Again, this is not a high quality data. It's not an RCT, but I can tell you how we do it. But also, like, having in mind that we have a neuroradiologist at site that finds us a leak usually within a day. So if we do have a fairly unsymptomatic patient, of course they do all have headaches, or most of them have headaches, then we often push through to find a leak, seal the leak, and the subdural will resolve. If it's a bilateral subdural, all patient at the age of 65 or younger, the likelihood of underlying spinal CSF leaks are really high. So we go for that, solve the leak, and there has been no redo surgery or reoccurrence of the subdural so far. But this is very one center only, our experience. Also with this high throughput we have. On the purpose of MMA, of course, this is important. It's something we do in our typical subdural cohort. This is something we approach regarding the timing. It's usually something we would currently do after recurrence if it doesn't resolve after that. But I'm curious to see how this evolves. I think there's another field and also another non-explored field, but subdurals are actually close by. But I think we have, within the group of subdurals, we will find a lot of CSF fistulas especially, and I think that's something that needs to be studied. And within the SIH cohort, so the younger patients, especially bilateral, we can push through. What we did if the subdural is symptomatic. So if we have some symptoms through the hemisphere where we have the dominant, or if there's some neurological deficit, hemiparesis, or patients really slowed down, then we do a mini twistal trepanation like a burhole trepanation, evacuated. And there is a lot of debate about whether this is doable too. You could imagine that you have caused more brain sagging. It's doable. So then we evacuate. Usually, but that's the high volume subdural walls.
Thank you.
And there is a paper coming out soon.
Okay, I've put in on the screen the only algorithm I found on the web, because it is almost not known how to treat them with the spinal leak, and this algorithm doesn't mention treating the leak, only mention epidural blood patch.
Absolutely. There are a couple of reports when the subdural resolved after blood patching. So getting the pressure up, so blood patching is something that's not wrong here. Like going like in a really symptomatic subdural and large volume hygroma subdural, it's also something like not to evacuate difficult. But we have good experience just going through, finding the leak, closing the leak, if we can. If we do have some problems within the myelogram, then we evacuate.
Thank you.
Okay, thank you so much, Katarina. If anyone has questions,
I'm happy to. I have no due date, no curfew.
okay.
Let me just say, I'm really happy that you all are here and still listening at this time of the day. And please reach out. We are really approachable, and just share your cases. You want to discuss cases, just do. All our emails is on out there, LinkedIn, or whatever you prefer to.
I can confirm that, and we're also glad for your collaboration and your expertise and your hospitality at your center. That was very inspiring for us, and that inspired us to build a team and go on to this pathology. And it is an honor for us to have you here, and I'm happy you presented your results, and not me, but because my skin incisions are much bigger than Amir's still, but we can improve. But it's a very an interesting field, I think, and an interesting pathology, and we could see surprising results.
Ilaria, excuse me. I think Professor Brogi wanted to do a question.
Couldn't see it, please.
Well, a compliment for this webinar, very interesting. The only thing that I didn't heard is the possibility to use a blood patch for this kind of syndrome more than the disease. And I think we have a large experience on that, and we published in 2010 on Journal Neurosurgery, for which are interested on that. That's the only thing. Compliments for anyhow for the presentation. Thank you.
No, thank you for sharing. Great.
So, if anyone has questions or invitations, okay, Katarina, thank you so much again. Thank you to Amir, of course, and thanks to Professor Becker that couldn't be here, but let you join us.
Yeah, he would love to. You know, we all love Italy and Italians. So happy to share anytime and come and visit. And you're always welcome.
Thank you so much.
Thank you for the invitation.
Francesco, ti ringrazio.
Grazie a te di averlo organizzato, visto che è stata una bella iniziativa, e soprattutto abbiamo iniziato con un argomento meno comune, mettiamola così, sì, di chirurgia spinale, ma delle dinamiche un po' meno note, tra l'altro con un'epidemiologia abbastanza significativa, quindi probabilmente c'è nella nostra pratica clinica un po' di non riconoscimento di queste sindrome. Ultimamente mi sono capitati dei casi analoghi, tra l'altro ho avuto modo di conoscere colleghi giusto la settimana scorsa a un evento ad Amsterdam, sono rimasto veramente affascinato dal loro workflow veramente molto importante. Thank you very much, Caterina, for your contribution. I'm really happy we started with this series of a webinar with this uncommon argument in spine surgery, but we discovered that it's not so uncommon. So thank you very much. Your workflow is impressive, really, and thank you for this opportunity and for sharing your experience. So thank you very much, and hoping to see you in some next event, probably in person, why not. So we